Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to What I Tell My Patients. As today we talk about the management of chronic lymphocytic leukemia. We have a great faculty for this program, and we're really looking forward to making rounds with them as we talk about this fascinating disease that's had such an interesting recent history. We're actually doing 10 meetings. This is the fourth meeting. We started out here yesterday. All these meetings have the same format and the same themes. Most importantly, we want to provide a research update to you of what's happened over the past year in clinical research in chronic lymphocytic leukemia and talk about what it means to patient care, particularly as it relates to patient education and getting patients prepared to receive new therapies that now are available. We also are going to talk a lot about patient education and particularly how to tailor what you say to patients based on their own individual characteristics. And finally, as we talk about patients, so the patients being taken care of by the nurse practitioners presenting cases here today, we get into the more deeper connection that happens between a patient and oncology care provider and the bond that the patient values so much. And also to take a breath every year and just say, thanks a lot, you're doing an incredible job, and people really value what you do. And I think the value of what you do just becomes evident as we talk about taking care of these patients. So great job. First, I want to introduce the faculty. We have a tradition. We don't talk a lot about burnout, but we kind of try to keep in mind that, a significant number of the audience has not been in oncology that long. So we want to first paint a picture about, kind of what things were like 5 or 10 years ago, but also get a little bit into how you can actually deal with some of the difficulties that patients and their families go through. And one important way is to just get away from your job. So when we introduce the faculty, we ask them to chat a little bit about what they do to sort of get away from their work. And I'll start out with you, Adam Katai. You're up there at Ohio State. What do you do to have fun?
Yeah, so I got 2 very young kids. One's 4, one's 2. And so most of my time is taken up by taking care of my kids. But I'm a big movie buff, and so I've been waiting for my kids to be old enough to go to the movies. And I finally got to take my son to see the Super Mario Brothers movie this last week, and he loved it. And so that was a really good sign for my future that my son would actually like movies just as much as I do. So really excited about that.
Awesome. John Allen, how about you?
Yeah, hi everyone. As I've gotten older, I realize how nice it is to just relax and actually do nothing on a Saturday and hang out with my 2 kids, which are 2 cats, by the way. But in reality, recently I collect vinyl. I like to listen to music. I also scuba dive. Those are a few interesting hobbies of mine.
Doing nothing's good. I like doing nothing. Erin, how about you? You're also up at Ohio State. What do you do for fun?
Yeah, I just like to. I have a 1-year-old that keeps me busy and entertained when I'm not at work, and like to spend time outside, hiking, and time with family. Also, during the week, just appreciate some good just couch time, watching some low-stress shows like Great British Baking Show, things that I can just detach. So
love baking shows.
Yeah.
I don't know. There's something about watching baking shows.
Really calming.
When there's no football, that's what I do too. So Jackie Broadway Duran, how about you? You're in Houston, not too far from here.
Yes, so I too, like Dr. Katai, like to sleep on the weekend, sleep in. After getting up every morning at 5:45, Saturday morning is golden to me. But I think the most eventful thing that's happened this past year, my son, well, it was not eventful that he fractured his leg, but he came to live with us for a while to heal, and he brought his dog, an Australian Shepherd. And I have never had a dog in my house. So this was a new venture for me. And at the end of the day, I fell in love with the dog. She was the sweetest thing. She became my little buddy. And then he came and he took her away. So now I'm back to the couch all day on Saturday.
Yeah, so Dog, cats, and little kids is a common answer that we get. I've got a 3-year-old granddaughter, too, who's also an incredible joy. All right, here's where we're heading. Talk about CLL. There's a lot to talk about. We've done so many programs on CLL in the last few years, we never get bored. Every patient's different. So we're going to start out providing a little bit of an overview of the disease, what makes it different, and it is a very different cancer to take care of. We're going to spend a lot of time talking about the initial therapy has changed dramatically over the years, and then we'll get into some new developments that hopefully are going to be translated into action in terms of actually reaching patients. So I want to start out with a patient of Jackie's, and I'm actually going to present it in 2 parts. I'd like you to talk about initially, Jackie, when you first encountered this patient, and like a lot of patients with CLL, she was observed initially, and maybe you can talk about a little bit about what it was like in the beginning when you started. You've been in this field for quite a while, Jackie, when you first encountered her, and what were some of the issues that came up when she was first diagnosed?
So this lady, when she first presented, she was on watch and wait for several years. She did develop autoimmune hemolytic anemia during that process and was treated initially for that. Afterwards, that resolved, and maybe about 5 or 6 years later, she developed a more progressive state of her CLL and presented with some bulky lymph nodes, and she was also having some drops in her hemoglobin and platelets. So at that time, we initiated her on treatment with obinutuzumab and acalabrutinib.
So before you kind of get into more details, let's just stop at that point and talk about the case up to this point, because this is a typical case for CLL. Adam, can you talk a little bit about, first of all, this idea of observation and how how patients react when you say, "Oh yeah, you have leukemia, but we're not going to treat it"?
Yeah. So. My patients like to call this phase in their disease watch and worry. And so a lot of the times I really try to talk about their symptoms, check in, make sure that they're feeling comfortable, and hopefully over time I hopefully assuage that watch and worry to really be that watch and wait period. And I try to remind them that most patients with CLL get diagnosed incidentally, right? So most of our patients are coming in, they're feeling good, not having a problem, they go to their primary care doctor for their annual visit, they get a CBC and their lymphocytes are high, and that's how they wind up in my clinic. And so they go from being a perfectly healthy person to coming in now with a new leukemia diagnosis. So I think one of the first things I start out with my patients when I meet them for the first time, and having reviewed their charts, knowing that they're going to be this person who's on watch and wait for probably a few years, if not more, the first thing I say to them is that this is called CLL. It's a chronic leukemia. It's chronic for a reason. People live with this disease for years and years, and our treatments work really well for years and years as well. So I think the primary thing that I do for my patients while they're in the watch and wait period is really just calm them down, really try to ensure that they're going to have a good outcome with this disease, because for the most part with this disease, many patients really do have good outcomes.
So Corinne, any thoughts about this interesting sort of state that these patients usually go through and what you've observed? And some people don't ever require treatment, they die of something else. What's your experience, Corinne, with patients in this sort of stage of the disease?
Yeah, I think, as Dr. Katay said, a lot of patients come in, you find out you have a type of cancer, you want to take action right away. So patients come into their new patient appointments thinking we're going to come out with a treatment plan. So it just requires a lot of education, not just at the first visit, but future visits to kind of calm their worry a bit. That we're watching closely, paying attention to see if they meet any of those indications for treatment. And generally we're able to get there, but it is a big learning curve for some folks that they have this diagnosis that we're essentially doing nothing but watching for a while.
Jackie, what was this lady like, and what was her life like during this period that she was mainly being observed?
Yeah, this lady was retired. She was a widow, and she had 2 adult daughters. They were all very close. She had a great support system. They were always there with her for every visit. And so she actually tolerated the treatment well without any significant problems, was able to get back to her socialite life. because she was an outgoing person. So I never saw her performance status less than a 1 throughout the process.
So, John, Jackie mentioned that this patient, like a lot of patients in this initial phase, had so-called autoimmune hemolytic anemia. Can you explain why patients with CLL get that syndrome and how it's managed?
Yeah, so fortunately, it's not an extremely common issue. It's about 15 to 20% of patients may have this develop in their lifetime or as a treatment indication, but it is something that is relatively common that we deal with, not just in CLL, but in lymphoproliferative disorders in general. But in CLL particularly, there is a T-cell, B-cell defect, and so they don't talk to each other very well, and there is this dysregulation of this immune system, and so you get dysregulated T-cells that then activate either CLL cells or normal B-cells, and then you have these abnormal B-cells that are also producing antibodies that can turn against our own body and cause these hemolytic anemias, these ITPs. And so it's really due to the dysfunction of the disease and the dysfunction and dysregulation of this immune synapse that, when it's normally in check, kind of controls this autoimmunity that, when it gets disrupted and out of a homeostasis, then you can turn on these autoantibodies. And essentially that's what we see happening in CLL.
And usually this gets resolved. How is it treated?
Yeah, so obviously when you start to see it, the typical standard approach for hemolytic anemias are steroids. In general, when you have a decent burden of CLL around, steroids in and of themselves may quiet it down. As soon as you try to start to taper them down, if the CLL cells and the process is still there, it's going to turn back on. So it's a treatment indication to eliminate the CLL population. And so we frequently do that various ways. Sometimes it's with steroids plus or minus, but in my practice, I frequently jump very early to spare steroids, jumping to anti-CD20 therapy, kind of like in this case with obinutuzumab, and potentially then even needing some longer-term therapy, more definitive treatment like the BTK inhibitors or even venetoclax adding on to that.
So we're going to focus a lot of our attention on the initial therapy for these patients, because it's a very interesting choice that they really have, at least at this point. Typically either a Bruton tyrosine kinase inhibitor or 3 available, some alone, or as in this case with an anti-CD20 antibody, or venetoclax with an anti-CD20 antibody. One important difference is, at least at this point, the BTK therapy is going to be indefinite, for the rest of their life, whereas the venetoclax is going to be time limited, usually for about a year. But before we get into that, and there's so much to talk about, not only about how the decision is made right now and what patients really need to understand about the decision and where things are going to be heading in the future, maybe combining BTK and venetoclax. But Jackie, it's also, to me, worth just taking a breath and thinking a little bit back to not that long ago. I mean, ibrutinib, the first Bruton tyrosine kinase inhibitor, was approved less than 10 years ago. And just to try, it was one of the most dramatic changes in the history of oncology when you bring in this targeted therapy. Because prior to that time, when patients got treated, they got chemoimmunotherapy. So they got chemotherapy. And now we shifted. Nobody thought you could ever get rid of chemotherapy, and now it is often not given in patients. Just kind of curious, before we start kind of getting into the data and sort of figuring out all the pieces of the puzzle, what it was like to see BTK inhibitors, specifically ibrutinib, come into practice in CLL. Jackie, you're at MD Anderson, one of the top CLL centers in the world, Ohio State, another top center, and also in New York. What was it like for the patients? How did it change quality of life to go from getting chemoimmunotherapy to, for example, ibrutinib, which was the first really novel targeted treatment?
I think they actually provided the patients more freedom to move on with their lives, because now you're not tied down to infusion centers and having to have treatment, especially the antibody therapies, which take several hours to infuse. So now, all of a sudden, they have this pill that they can take. Actually, there's several pills, once a day dosing. And so it was definitely a positive shift in paradigm for the patients as far as their lifestyle.
I guess the other issue with novel therapies is often their tolerability issues. And again, all week long, we're talking about new agents, what the side effects are. There are very few that are completely 100% specific in oncology, and that certainly applies to Bruton's tyrosine kinase inhibitors. Now there are newer agents. She's receiving what's considered second generation acalabrutinib, another drug just approved in the last few weeks, zanubrutinib, less toxicity. Maybe not necessarily greater efficacy, but maybe. Just kind of curious, John, again, sort of looking back in terms of how this wave of targeted treatment that has come in with ibrutinib leading the way, how has it affected, again, from your point of view, quality of life for patients?
Yeah, I mean, I think these drugs as a class have changed how we manage not only CLL but lymphomas in general. They've really made a huge breakthrough and a huge step forward and are very important. Ibrutinib is a great drug, and it works really, really well, and it's really well tolerated, and, but as technology advances, as research advances, we can fine-tune issues when we find with some of these agents. And so we get second generation, third generation drugs, and there is improvements upon those. And obviously, as time has gone on, BTK inhibitors have toxicities. And what we've learned, as you get more selective in terms of inhibiting just BTK and less other enzymes within the cell, you can start to mitigate some of these other toxicities. And that's what we've seen over the years of where newer drugs have come around, like acalabrutinib and zanubrutinib, have shown equal efficacy, but have had these decreased toxicities, and therefore patients are now able to stay on the drugs for longer. They're much more compliant. They're less afraid to have to start treatment as they're learning of this new data and these new drugs that are available. So in terms of their quality of life, it alleviates fear, it alleviates concern, alleviates uncertainty, because now we have a lot of follow-up time understanding the safety and the efficacy well into the future and can really lay out what the next few years of their life are going to look like.
So one of the main themes of all of these programs that we're doing here is what we call oncology strategy. How does the oncologist take the available clinical research, the guidelines that are out there, the FDA indications, and come up with a plan for a patient in a specific clinical situation? And today we're going to focus a lot on first-line therapy. And one of the themes within that, Adam, we talked yesterday about, is tissue biomarkers and assays that can be done to assess potential response to treatment and also long-term prognosis. And we've known for a long time that there's a subset of CLL. You can talk about what 17p is and del P53, that even when we were giving chemotherapy was difficult. And then when these new drugs, particularly ibrutinib, came in, that was the first thing that people thought about. Is it going to work in these high-risk patients? Which it seemed to completely. Can you explain sort of how you look at sort of the various assays, particularly these high risk, and decide whether or not a patient fits into this high risk category?
Yeah, so I think there are a couple of different assays that we get for patients when they are diagnosed, and sometimes we repeat them when it's time for treatment. It kind of depends on how long time has gone on. So one is IGHV status, and that could be either mutated or unmutated. And although it's counterintuitive, the unmutated is the one that carries higher risk. There's FISH assay as well as karyotyping, and those measure the chromosomes within the CLL, just two different methods of doing that. And on the FISH, we have the deletion 17p that Neil was mentioning, deletion 13q, trisomy 12, and the deletion 11q. On karyotype, we have all those same things, but we're also looking for complex karyotype, which is defined as over 3 abnormalities. And the last is a sequencing panel. Normally talked about next generation sequencing. You might have heard this. Each institute has various different panels. It kind of depends on the state that you live in. For instance, at OSU, we have a 50 gene panel, whereas there's an institution in New York where they have over 400 genes that they look at. But specifically, the one that we pay attention to in that panel is TP53, which is a mutation that's also on 17. So it's linked to that deletion 17p. So now when we take all these things into consideration, really the highest risk patient is going to be someone who has complex karyotype and has deletion 17p or TP53 mutation. And the reason why we consider these to be the highest risk individuals is that they continue to do worse even with our modern day therapies. So these factors continue to come out as independent prognostic markers of survival for patients who are treated with the BTK inhibitors and venetoclax. So that's why we call them the highest risk. The other one that we still pay attention to is IGHV status. Although patients with IGHV unmutated status are doing very well on our current trials, it appears that long-term studies show that unmutated still confers a poorer risk for our patients. So in general, it's sometimes changing the treatment that we pick. Some people will argue to use BTK inhibitors for patients with higher risk disease, but that's not a sure thing. It really kind of depends on the patient that you have in front of you. But the highest risk patient is going to be those patients who have complex karyotype, deletion 17p and TP53, plus minus IGHV unmutated status.
So we'll talk a little bit more about Jackie's patient in a second, but just again, getting back to the pre-ibrutinib days, Jackie, there was a regimen that's rarely given called FCR, a very difficult chemotherapy regimen. Now it's, I don't think used very much, but particularly used in these higher risk patients that Adam was talking about. Can you kind of contrast what it's like to give a patient FCR versus ibrutinib? I remember when those studies came out comparing the two, it was hard to believe that a much simpler oral pill could be better than this very intense chemotherapy. What did you see when you gave people FCR, Jackie?
Patients who were treated with FCR, patients presented sometimes with problems with nausea. Then you had problems with, things that would go along with chemotherapy, maybe the fludarabine, and they end up having peripheral neuropathy and those type things that show up. There was also some late data that came out with after treating with patients with that treatment as well as R-CHOP. Not only did they develop peripheral neuropathy, but some of these patients later developed myelodysplastic syndrome. And so those are things that we kind of were able to get rid of being concerned over when we started using the more targeted therapies. So those in particular have been such an improvement. Again, the patient's lifestyle has changed because now you don't have to worry about a schedule to get chemotherapy and which days and how long and all of these things. So the patients with the oral medications, the BTK inhibitors, I think that has improved their lifestyle significantly.
And John, another thing we've talked about conceptually is the idea of so-called phase 3 trials, which are large studies that compare standard of care to something new. Can you talk about some of the early studies that came out using first BTK inhibitors in these situations, what was seen when they were compared to chemoimmunotherapy, and particularly what was seen over the long term? Because as you followed these people, 5, 6, 7-year follow-up, they weren't progressing. Can you kind of summarize what we learned about the impact of BTK inhibitors, particularly ibrutinib, in the beginning?
Yeah, most drugs are developed in early phase studies where you kind of find a relapsed population and test safety and efficacy, first safety and then efficacy. As you develop them, it's usually starting out in these relapsed patients, and obviously drugs like BTK inhibitors like ibrutinib first started to hit the clinic in clinical trials back in 2010 or so. And fortunately, I work with one of my colleagues, Dr. Furman, who is one of the first people to dose patients with these BTK inhibitors. These were patients that some doctors were sending to hospice that came to get on study, and all of a sudden were having these remarkable remissions. And some of them literally on the very first initial studies were still 8 years later alive on these drugs and not breaking through. So it became very early evident that these drugs were different than your kind of routine testing it out, and somebody may have a remission for like a month or 2 months longer and had some toxicities. Not only was the remission quick, durable, but the toxicity was kind of unprecedented comparatively to some of the options that we had with chemotherapy, which is what some of these patients would just had repeated courses. They were immune suppressed, and they were having complication after complication. And so it really opened up this new world of targeted agents. and where basically in the past decade, where a lot of most development of new drugs has been in a targeted manner, whether it's monoclonal antibodies, antibody-drug conjugates, or small molecules that are really targeting the pathway that is disrupted. And this speaks to more of our genomic techniques and our understanding in the lab and all of the research that goes decades even before the development of these inhibitors. But we are in a new era where we are really looking to phase out chemo for most indolent lymphomas and utilize targeted agents that really expose and exploit the underlying biology that these cells are addicted to. And this is a perfect example of that with these BTK inhibitors.
You know, it's interesting. I don't know, somehow talking about how this all started, I was flashing on one of your colleagues at MD Anderson, Dr. Hagop Kantarjian, and I remember working with him around that time, and he said, I think CLL is going to become the new CML. And you know, CML really was the first model for targeted therapy, and basically at this point now, these people live normal life expectancies, but they need to be treated for life. And looks like we're kind of moving in that direction. People don't die of CML anymore, they die of other things, and really that's a goal in the CLL patient. One of the other issues, though, Corinne, is that we have mentioned here is because of the baseline lack of immune function, increasing risk of infections, and also suboptimal response to vaccination. I'm curious how that has played out clinically, what you observe in these patients when you need to use IVIG, and also what it was like during COVID.
Yeah, so I guess first backing up to COVID, obviously a very anxiety-producing time for us in the clinic, but also for our patient population, because most CLL patients know that they will always carry higher risk for infection due to their underlying immune dysfunction. So there was a lot of talk about vaccines, during that time, and also knowing, like studies showing that the responses to vaccines are overall suboptimal compared to those without CLL. So we still always recommend the vaccines, regardless of knowing that response can be hampered. We do feel like they still provide benefit, and we're hopeful that they lessen the severity of infection, COVID infections, especially for our patients. In terms of supplementing with IVIG, that's kind of on a case-by-case basis. A lot of patients have a low immunoglobulin G level, and if they're having recurrent respiratory infections, hospitalizations, pneumonia, that's a patient that we believe to be a candidate for some supplementation with the IVIG.
So let's get some follow-up on this 70-year-old woman who eventually did have to be treated. A lot of people will just get a BTK inhibitor by itself, but we have seen data that by adding in, particularly with acalabrutinib, the anti-CD20 agent obinutuzumab, you get a little bit extra bump. This lady had a lot of disease. You were mentioning a big bulky disease. She actually got to do obinutuzumab first to kind of decrease it down, then brought in acalabrutinib. How did she do, and what happened, and what's her current situation?
This patient is doing very well. She's tolerating the acalabrutinib. She's back to doing all the things that she wanted to do in life and traveling with her daughters. She has not had any significant side effects from the acalabrutinib, and so we're happy and she's happy. So when patients are happy with their medication, they feel better and see that their life is improved, they're going to be more likely to be compliant and take their medications as they are prescribed.
What do you usually go through with a patient who's about to begin a BTK inhibitor, let's say acalabrutinib, and what was it like to talk to this woman as a patient? How was she as a learner or as a patient in this situation?
So the first thing I usually do when I'm talking to a patient about a BTK inhibitor is try to explain the mechanism of what the drug does in their body. It's also important to talk to them about drug adherence. But one of the most significant things I found that's important to educate your patient on of how the mechanism of the drug works, so that when they develop this rebound leukocytosis, then they just not freaking out and thinking the drug isn't working. And that has happened. I had a patient who We started her, she was doing well within the first 2 weeks, 2 or 3 weeks of her Acala. And she went out into the community and she was developing this lymphocytosis, or leukocytosis. And her local PCP said, you need to get back immediately because this drug is not working. Your white count is getting higher and higher. But because I educated the patient, she was well aware of this effect. And so she wasn't alarmed by that. So I think that is a very crucial teaching point for those patients starting on these BTKIs.
Yeah, that's a great point. Initially, you would see the white count often will go up. Nobody's sure exactly why it happens, like it's coming out of the bone marrow. I know, John, any thoughts about why you see this? And how long does it last that they have? That's often the first thing you know about was all your white counts goes up. Now you start the therapy and the white count's going up even more. How long does that happen for? And any thoughts about why it happens?
Yeah. So it's a phenomenon that we recognized early, and again, I think I can't stress as much of importance as what has been said is education and setting these expectations. But it's pretty well understood mechanism of inhibition. So there is a pathway that keeps these cells stuck in the lymph nodes and in the bone marrow, and the BTK inhibitor, ibrutinib, Acala, zanubrutinib, also inhibit this pathway in addition to the B-cell receptor pathway. And so by inhibiting this pathway, basically it loosens the cells up and they spill out into the blood because these drugs don't kill instantly. They kill by kind of energy, essentially, and just starving the cells of the signal. So what we see, and how you know it's a normal thing, is that patients will feel better, literally days after taking the medicine. They will feel their lymph nodes shrinking, but when they come back in a week or two later, their white count's actually going to be higher. So it's those two combinations, feeling better, lymph nodes shrinking, that in combination with this white count rising is a normal expectation. We typically see it peak at around 2 months, 2 to 3 months, you'll see it peak, and then it can normalize over the course of another 9 months, and I've had patients who have pushed their white counts up to 300,000-400,000 before, take almost 3 years sometimes to completely normalize it. But every time you see them, it comes in and it's lower and lower, and finally it normalizes. So these are all expectations to set with the patient so they don't see their portal and freak out when the ALC is still a little bit higher. And it's, again, education, and now that we know this is a well-described phenomenon.
So, yeah, while you can talk about CLL every day, I never heard, of all the programs we've done at CLL, I never heard anybody talk about this other mechanism you just talked about. That's super cool. It makes sense. I just never heard it before. Absolutely. There's just a lot there. All right, we got another case from Corinne, where we're going to bring in to, again, sort of get in to the clinical issues. This patient received a different BTK inhibitor, zanubrutinib, again, just recently approved. Before we hear about the case, though, I want to come back to Adam. We've already, in some of the programs we talked about, been talking about, for example, TKIs that are not pure. They hit multiple targets, not just the one you want to hit. And that certainly happens with BTK inhibitors. Before we kind of differentiate, the ones that we have right now and some new one that just got approved for that matter with a completely different mechanism, can you kind of provide an overview what kind of tolerability issues come up with BTK inhibitors?
Yeah, so it turns out that the toxicities associated with BTK inhibitors are probably a class effect. Where we see the same toxicities over and over again, but with the first, second, third generation BTK inhibitors, they seem to get less and less as the drug gets more targeted to just BTK. And so those toxicities are joint pains, palpitations, which makes you think about atrial fibrillation and cardiac arrhythmias, including ventricular arrhythmias, easy bruising and bleeding, and hypertension. So those are the 4 that I typically pay attention to for BTK inhibitors. Of those toxicities, typically it's the hypertension that gets worse over time, whereas the other toxicities tend to get better over time. So pay close attention to hypertension because patients may need to be on multiple blood pressure lowering medications, and especially when we're dealing with this elderly population who are mostly men, they can really increase their cardiovascular risk.
Yeah, we were talking about in the program on endometrial cancer yesterday, a TKI lenvatinib, again, hypertension in some cases is a very serious problem. I think lenvatinib even more so than the BTK inhibitors. All right, Corinne, let's hear about this 70-year-old lady. What happened with her?
Yeah, so the time came, she was followed with observation for several years, but then started developing some progressive anemia, thrombocytopenia. Fatigue started to get a little bit worse. As you probably know, it's always hard to kind of tease out fatigue when someone reports. That can be for many different reasons. So we first kind of ruled out some other causes of fatigue, but then finally made that decision that it was time to initiate some first-line therapy. Fortunately, she had a pretty unremarkable health history, no cardiac history. And so the various options that were presented to her by her oncologist were venetoclax obinutuzumab, which is a limited duration therapy, zanubrutinib, and acalabrutinib. And for her, it was really important that she kind of maintain her flexible lifestyle. She likes to get up and go and fly to Texas to help babysit her grandchildren because her son and daughter-in-law travel often for work, so she wanted to kind of maintain that flexibility and was quite intimidated by the venetoclax ramp-up phase. So then it came down to deciding between zanubrutinib and acalabrutinib, and given her past medical history of just headaches and migraines, she was a bit kind of spooked by that side effect with acalabrutinib. We did provide some reassurance that those headaches often abate with time and are generally pretty manageable, but that kind of led her to decide on zanubrutinib.
And how's she doing?
She's doing really well. As you mentioned, it has newer approval for CLL, so she's only a couple of months in, but she is kind of having good quality of life. We, continue to remind her of things to watch for, especially since she's not home often and travels. She has to kind of be mindful of when something might need evaluated, like if she has an infection locally, reporting any issues with bleeding, things like that.
So, Jackie, it's interesting. I can't think of maybe there's another situation in oncology where headache can be a side effect, but we've been hearing about that with acalabrutinib. Also, a lot of people say for some reason caffeine works with these. Cuban coffee here, we're in Miami. Any comments about clinically? The other story I hear is usually these go away and it really doesn't much of a problem. I mean, we have 2 second-generation agents, both approved, that are utilized. It's hard to say which, we have to sort of indirectly compare them. Another thing that was a factor was in times a day, zanubrutinib, it can be either once or twice. Acala is twice a day. Any thoughts about sort of choosing between these 2 really good options and your experience with headaches?
As Corinne stated, if a patient already has a known history of headaches or migraines, certainly you want to look at the zanubrutinib versus acalabrutinib. However, in the acalabrutinib, these headaches are usually transient and they usually get better over the first 3 or 4 months or so. But we have had patients who were unable to rid of the headaches and didn't want to be on medication to manage them. So there have been cases where we have switched them to zanubrutinib for that reason. But it's important to talk to your patient because they will tell you it doesn't do you any good to say, I'm going to put you on this drug. You got to take it twice a day if they have an option where they can take this drug once a day, and especially if they already have all these other comorbidities, because as we know, most CLL patients are older patients. So if you learn your patient and you know that they're more likely to benefit from both drugs and you think the patient is going to do well on once-a-day dosing, then that also may be a deciding factor.
So, it's great to have more than one option. There's so many situations where you have that in oncology now. We were talking about breast cancer last night. There are 3 CDK inhibitors. You start one. If they have tolerability issues, you have others. So it's great. Now we have 2 really good agents. Kind of hard to separate them. Another way, Adam, that you could separate it up until a few months ago was that until a few months ago, if you gave acalabrutinib, the patient couldn't take a PPI for reflux, and et cetera. Now they have a preparation. Any thoughts about how that affected your decision-making when this new formulation came out?
Yeah, I think this was kind of a game changer for our patients. Everyone has GERD. Everyone's on the H2 blocker, whether they're telling you they're taking it or not. So the moral of the story is that for our patients who were on a PPI, not an H2 blocker, they had to take it 2 hours after taking the acalabrutinib, which really made it difficult, and you really weren't even supposed to do that. So the company switched the acalabrutinib from a capsule to a tablet formulation, and with the tablet, you don't have to worry about a PPI or H2 blocker anymore. So no worries there with acalabrutinib.
So another place where BTK inhibitors are used in mantle cell lymphoma, we're not talking about it this year at the ONS meeting, but these agents are used in second-line therapy and now being looked at in first-line therapy, and all three of these BTK inhibitors are available. But, John, there was another BTK inhibitor that was just actually approved in mantle cell, but we have a lot of data in CLL, and people, I would imagine it's going to get approved in CLL too, because the interesting thing is this agent, pirtobrutinib, which as you can see here is fundamentally different in that it's a reversible versus irreversible, the ones that we're talking about, different configuration. But most important clinically, if you take a patient the unusual patient who has disease progression on a BTK inhibitor, these people respond to pirtobrutinib. So nowadays, usually you're going to get a BTK inhibitor, you're going to get a venetoclax, and after that, we hadn't have any really great stuff. John, it looks like pirtobrutinib, there are other options that can be considered. Any thoughts about that? And also how it differs in terms of tolerability and safety compared to the BTK inhibitors we have right now, particularly cardiac issues.
Yeah. So pirtobrutinib is I guess we can consider it maybe a third generation BTK inhibitor. It is different than the previous three that are FDA approved for CLL in that it is reversible. So the other drugs work by inhibiting the protein BTK by covalently binding the kinase pocket, blocking its signaling. Therefore, that enzyme is knocked out. The only way to reestablish it is to resynthesize the protein, which the next day you take the pill, you inhibit the newly synthesized protein. One major mechanism of resistance to those drugs in high-risk patients is to mutate the binding of the covalent molecules to the protein. And so basically the mutation causes the drug to basically fall out of the pocket, and therefore the enzyme is no longer inhibited. These drugs typically have short half-lives. They get washed out of the body very quickly, and sure enough, when you have this mutation, the B-cell receptor pathway starts to signal again throughout most of the dosing interval. Pirtobrutinib is different in that it has good PK, in that it can hang around in the body for a very long time, but it doesn't require binding into this pocket on that cysteine 481 residue. And by doing that, it can get into the pocket, inhibit the phosphorylation downstream, and therefore reestablish inhibition of that pathway. And what we've learned from the clinical trials that got its approval in mantle cell lymphoma, in that study there was actually many more patients with CLL, I think close to 300 plus patients with CLL treated with it. And what we saw is that these patients who had resistance disease to BTK inhibitors, the covalent ones, could actually get nice durable remissions and have great efficacy long-term with this new drug. And so right now it's being developed in a niche to overcome resistance, but based on the safety of the drug, what we were seeing, because it's not inhibiting it fully, constantly, as well it's also very, very clean, doesn't inhibit a lot of the other enzymes, the safety profile currently at about a year of follow-up looks maybe the best of all the BTK inhibitors. We don't see a lot of bleeding. We don't see a lot of AFib. You still see BTK class effects, as Dr. Katai was saying, but they're just at much lower rates than we've ever seen historically speaking. So to your point, these drugs are being developed in CLL, and they are moving up into the front line, and it is very possible that this drug displaces, this whole class of drugs displaces our covalent-bound BTK inhibitors because of the safety aspect, and the current data suggests that they are almost they are going to be effective, but we need that long-term data, and right now that niche is in this relapsed refractory setting. But stay tuned. In another 5 years, we may be saying a different story, and these may be the drugs that we now have 3 or 4 of those that are differentiating themselves.
I mentioned the fact that we've been coming here for 15 years, and every year I imagine, like, what are we going to be talking about next year? And every year there's like tons of new stuff to talk about. So great for patients, but also challenging for the docs. One other issue, Adam, a lot of times, again, we have multiple drugs within a class. It's kind of hard to separate them. Sometimes a lot of them you'll have similar efficacy, but we've been talking about slightly different toxicity. But we're starting to see some data, maybe the possibility that some of these BTK inhibitors might be better than others. And we have started to see, particularly at the last American Society Hematology meeting in December, some data suggesting maybe that zanubrutinib actually might have somewhat better efficacy than ibrutinib. And then there's a lot of debate about whether or not that really is true or not. Maybe it has something to do with the way they did the trial. Any thoughts about, at least in terms of these second-generation agents, whether we're going to be able to differentiate them based on toxicity, or because they're not compared directly, and you're going to have to just sort of choose between the two?
Yes, that's a great point. These drugs have not been compared versus each other, so anything I'm about to say is really anecdotal and kind of derives from the trials where these drugs were compared to ibrutinib, right? So there was 2 studies in the relapse refractory setting. One was the Alpine study that compared zanubrutinib to ibrutinib, and the other study was Elevate-RR, which compared acalabrutinib to ibrutinib. The studies were designed a little bit differently. So Elevate-RR had deletion 17p patients and deletion 11q patients, and you had to have one of those abnormalities to enroll onto the study, whereas the Alpine study did not have that requirement. And so it's really hard to cross-compare these trials because it really was a different patient population. In the Elevate-RR study, that study was designed to be non-inferior, meaning that they proposed that acalabrutinib would be non-inferior to the efficacy of ibrutinib and had some key secondary endpoints of being better at atrial fibrillation and some other cardiac events. The Alpine study was designed to be superior in terms of the overall response rate, and it looks like they hit that mark where they did have a superior overall response rate compared to ibrutinib, as well as a superior progression-free survival compared to ibrutinib. So whereas Elevate-RR did not show an efficacy benefit, but did show a safety benefit, zanubrutinib versus ibrutinib in the Alpine study showed both an efficacy benefit and a safety benefit. So when I'm thinking about these 2 drugs and the different adverse event profile of each, they're a little bit different, but it's kind of hard to say because, as I said, they haven't been compared head-to-head. So one thing to pay attention to with zanubrutinib is that zanubrutinib, when it was compared to ibrutinib, had equal rates of hypertension, whereas in the Elevate-RR study, acalabrutinib had much less hypertension than ibrutinib did. So if I'm looking at a patient with hypertension, I would choose acalabrutinib. In acalabrutinib, we talked a lot about the headaches. So if someone has a history of migraine and lots of headaches, I would tend towards zanubrutinib. But once again, I'm really crossing hairs here. I'm really trying to pick apart things to pick one of the drugs. But both of the drugs are very good and very well tolerated. But I would tend to pick acalabrutinib in somebody who has a history of hypertension, and I would tend to pick zanubrutinib in somebody who has a history of headaches.
And a lot of times the guidelines don't, they'll say, well, all 3, even ibrutinib is a reasonable consideration. You just, they're all great choices. If you think about it too, a lot of people value longer-term data. The longest-term data we have is with ibrutinib, then acalabrutinib. People get used to using drugs and you feel more comfortable. So options that are all great. Just a couple more points before we get into the other main option, which is time-limited therapy with a venetoclax combination. Back to you, Corinne, in terms of tolerability issues. One of the other issues here with BTK inhibitors is increased risk of bleeding. And I'm curious how you see that playing out in your practice. I hear people talking about like bruising on the arm. What do you typically see? Do you ever see major bleeding events? Also, I think Adam referred to ventricular arrhythmias. He didn't elaborate, but like ventricular arrhythmias can mean sudden death. There have been a few cases reported, I think mainly with ibrutinib, and I think you all reported a couple cases also with acala. But what about the bleeding? What do you see, Corinne?
Yeah, so again, this is another adverse effect I try to educate patients up front about, because they do start noticing this easier bruising from this, platelet changes, dysfunction it causes. So a lot of times they'll it's not so much, It's cosmetically bothersome, but does take them by surprise. They'll come in for a follow-up, and you see on their forearms or where they had blood sticks a lot of bruises, and it does bother patients sometimes. But generally, we get through that. But with the bleeding, we always ask patients at follow-ups, do you have any surgeries planned? And constantly remind them of that bleeding risk, because sometimes as you've been on the medication, it's easy to forget about some of that stuff discussed up front. So I always ask about surgeries or any procedures coming up that might pose a bleeding risk, because we generally have them hold the medication depending on what procedure they're undergoing to help kind of mitigate that bleeding risk.
So let's talk about the other major decision that's a consideration as first-line therapy, which is venetoclax, again, usually in combination with the anti-CD20. This can be as first-line therapy, which we're talking about, but also if you start out with a BTK inhibitor, you can go to venetoclax second line. If you start out with the venetoclax first line, you can go to BTK inhibitors. So usually this is going to be the first two therapies unless we start combining them, which may be going to happen. We'll get into that in a second. But let's just get into the issue of what happens and what you say to a patient who's about to begin the venetoclax journey. What was the situation with this 65-year-old woman, Jackie?
So this is a lady who was still vibrant and young and wanting to move about, but she came in she saw her PCP due to significant fatigue. And they drew a blood count, and they noticed the patient had, abnormal blood count. So she came to MD Anderson without any prior treatment history, and she had really large, bulky nodes. And so we decided to go ahead and admit the lady. She was admitted to the hospital for debulking because we were obviously you're going to have a concern for tumor lysis syndrome with someone that you're treating with bulky adenopathy. She tolerated the obinutuzumab. She made it through the first month, and then we added the venetoclax. So one of the problems with this lady is that we have had intermittent problems with neutropenia since adding the venetoclax. And so we managed to, a couple of times we had to interrupt the dose and give her growth factors to get her through those periods. She is now has just recently resumed back up to the 400 milligram dose. But so you just have to work with the patient and dose reduce them. If the patient has continued problems with severe neutropenia like grade 3 to grade 4, the oncologist then may make the decision to permanently dose reduce them. So those are some of the things we have to consider.
All right, well, let's sort of backtrack into a number of the things that you mentioned and sort of talk about sort of where this comes from. First, maybe we can just start out and talk about how this fascinating drug works. Of course, we're going to talk on Saturday morning about venetoclax and AML and also MDS, where it's been revolutionary, really amazing, taking people who used to go to palliative care and now throwing them into remission. But it's also had a similarly powerful impact in CLL, now another option as first-line therapy. Adam, can you talk about your vision of how it works and how do you explain to patients how it works?
Yeah, when I think about how it works, I think about this picture. It's very suiting for Texas, this picture here. The BCL2 family member proteins are these group of proteins that live on top of the mitochondria. And at any given time, they're in a balance between the pro-apoptotic proteins, the ones that cause the cell to die, versus the ones that are anti-apoptotic, the ones that cause the cells to live. And as you would imagine, cancer cells like to upregulate those anti-apoptotic proteins because it tells the cell to live longer. As we know, cancer is a disease where cells divide very fast and live longer than normal cells. So what this drug does is basically recounterbalances that balance between the anti-apoptotic and pro-apoptotic proteins, causing the cells to die when they otherwise would have lived. So that's what venetoclax does.
So I guess a fascinating thing, when I first heard about it, I was like, whoa, that sounds amazing, which is the cells die so fast, John, that you can get a syndrome called tumor lysis syndrome because the cells are dying too fast I mean, maybe you can tell me biologically your vision. You explained why the white count went up. Maybe you can explain this to me. But why do you see that? What is this syndrome, and how do you prevent it?
Yeah, so in the early phase studies, there were actually patients who died from getting this drug, and so we didn't really, we being the docs who are running the studies then, were giving big doses and starting out at big doses, and there was not a recognition of how good this drug works. And basically, when the patients got to a higher dose level, and they took that higher dose level as their first dose, because these patients were in relapse refractory diseases states, they had big bulky disease and a lot of CLL around. And by having these higher doses, it became very evident, very clearly, that this drug was very, very effective. And so patients were starting to develop tumor lysis syndrome. And tumor lysis syndrome is essentially, it's kind of what we want to see in any cancer therapeutic, basically, because it tells you that the cells are dying off very quickly. And in fact, it's something that is encouraging when you see that activity, but it can be very, very dangerous because it can get out of hand quickly. And so when you get overwhelming cell death, basically the electrolytes that are within the cell, they spill out into the blood. You get hyperkalemia, hypocalcemia, hyperphosphorus. You start to spill out uric acid. This then leads into damage to the kidneys. It can lead into cardiac arrhythmias. And then patients basically can have sudden death and ventricular arrhythmias and go on dialysis and can die from this syndrome. And so it's one of these things that when it starts, it's not so simple to stop it until the drug kind of washes out and stops its effect. And so we saw this. And now, once we recognize this, there were drug holds and clinical trial holds. They reestablished a dose ramp-up schedule for which we still use today. And by implementing basically a 5-week ramp-up schedule of baby doses first and watching labs and watching the patient closely, and over each week, you increase the dose slowly and gradually. Once this was implemented, basically tumor lysis went away, and it's not really a problem anymore. The downside of this is this makes this drug that we use much more complicated logistically, as well as difficult for certain physicians in community practices that can't turn around labs quickly to understand what's going on. And so logistically, it complicated the regimen and is a major reason why BTK inhibitors are sometimes favored over venetoclax-based approaches, because the BTK doesn't seem to have this problem, and it's just so easy to start. You can start the drug, and you can see the patient back sometimes 2 weeks or even a month later and know that nothing's going to happen to them in that period of time. Whereas with this drug, you have to be watching them kind of like a hawk, and this is the major differences that come into treatment decision-making with these two agents.
And one of the strategies that's come about, because if you look in the package insert for venetoclax, it actually has a table that tells you what to do based on what the white count is and how big the nodes are. The more tumor you have, the higher the risk. And if it's high enough, as with this patient, you actually put them in the hospital so they can be observed. But Jackie, one of the things that's come about in more recent years is, like, quote, debulking these patients. So reducing the tumor bulk with another therapy, specifically the anti-CD20 that's part of this regimen. So starting the CD20 first, getting some tumor reduction, and then by the time you're giving them venetoclax, the risk is much less. Is that a strategy right now that you generally using?
Yes, we do continue to use that strategy. And as stated, it's very rare that we see anyone with tumor lysis syndrome. Even if the patient, so they are categorized or stratified into 3 risk categories. It's low risk, medium risk, or high risk. And that will determine whether or not that patient needs to be admitted overnight and given copious amounts of IV fluids to try to prevent this tumor lysis. But it's also important when you educate your patients that when you put them on allopurinol so that the uric acid level doesn't build up to a toxic level, it's important for you to explain to them it's important to take the drug. Because if you don't tell them that, they're being overloaded with information, and sometimes they'll see this drug, okay, I picked it up from pharmacy, but I wasn't sure exactly when I need to start it or stop it. So those are teaching points, again, for your patient. But yes, with the use of using those anti-CD20s ahead of time, We just don't see very much at all of tumor lysis.
So, Adam, from a clinical point of view, when you have two different therapies, different approaches, one is indefinite, the other is short-term, but has, this a more complicated issue. What you want to see is a trial comparing the two to see whether or not their efficacy is the same or tolerability. And I guess we don't have that at this point, right?
Yeah, I think the first trial to report combination therapy versus single agent therapy will be at ASCO, so that's going to be IVO versus IO. But there's not much data out there on single agent VEN versus a BTK inhibitor. So I think the first study that will be reported is CLL17, but that's really far away. And in that study, it's ibrutinib plus venetoclax versus venetoclax plus obinutuzumab versus ibrutinib alone. And so it's a long time coming, but eventually we'll have that data.
So the message that I was getting that we were trying to put out through you all, let's say I can think back of maybe 3 or 4 years, was they're both good options. We can indirectly compare. It's hard to say there's much of a difference. It's really patient choice. Lifestyle. Do you want to be treated indefinitely? Do you mind coming in for infusions or getting your blood drawn, et cetera? And that was kind of the way we've been approaching it. And then COVID came along. And everybody wanted to stay out of the hospital. I'm just kind of curious because that was just at the point that we were kind of priming up these two options. And then we had another consideration, which is people don't want to come in the hospital, et cetera, et cetera. How did that affect it? Did you think were there more people getting BTK just to keep them out of the clinic?
Yeah, I wouldn't say there were a lot, but I do think at that time, we wanted to keep people out of the hospital setting as much as possible. Also, the neutropenia that can come with obinutuzumab and venetoclax also kind of swayed our decision to kind of maybe shift towards starting people on BTK inhibitors at that time and maybe saving that other option down the road.
So, Jackie, what do you talk to patients about when they're going to get venetoclax? One of the issues we mentioned here is the potential interaction with other agents, for example, antifungals,
yes.
And the need to reduce the dose. But from a practical point of view, what are some of the things that you go through with these patients? And how did you assess this patient in terms of her ability to follow the regimen?
Oh, that's very important you get to know your patients well and know those that are more likely to be compliant. So it's important to tell them that this has to be taken every day. We have a sort of a contract that patients agree to, that they're going to stay compliant and adhere. The other thing I try to always reiterate is that, we talk about the drugs that may interact on that same pathway that this drug is metabolized. And so I always tell them every time, bring your list of medications into the clinic so we can review them. And, we had one patient who was taking 43 different supplements. And, of course, nobody knows exactly what's in some of these supplements. And so he said, well, which one should I lay off of? I said, all of them. Just only take, just take the basic stuff. And, again, you have to avoid grapefruit and Seville oranges and star fruit and those types of things. But one of the main things I really push with them is water. You have to stay hydrated. You need to keep those kidneys flushed. That's very, very critical. And, of course, there's always the age-old argument, I don't like water. I said, well, come to like it. And they have all types of flavor package you can buy to put in your bottle of water, but however you need to get it in. So one day I said to a man, you got to drink. And he said, does that include vodka? So you have to be specific when you tell them about hydrating, what they need to hydrate with.
So one of the things that's come about, we were talking to Adam yesterday about cell-free DNA assays that are being used in solid tumors, particularly in colorectal cancer now, determining whether or not people get adjuvant chemotherapy. They ever look for fragments of DNA in the blood and whether it goes away or whether it's present in terms of whether to treat. And that kind of flows also out of a concept that's throughout hematologic oncology, the so-called minimal residual disease. And we're seeing more and more patients get these assays done. Can you explain what that assay looks at, and particularly as it relates to venetoclax, how it's utilized, these patients, when they get upfront treatment with, say, venetoclax and obinutuzumab, it should be for a year. But then when we look at MRD, sometimes we see that the disease, there's still evidence of the disease. People talk about, well, should you continue it or wait? A lot of times you can just stop the therapy at a year and they may not need treatment again for 4 or 5 years. What is MRD and how are we utilizing it, Adam?
Yeah, so this is a really controversial topic in CLL. So MRD stands for minimal residual disease, and whether you can detect it or not detect it. So detectable versus undetectable. Undetectable MRD is what you want. So you can either test this in the peripheral blood or in the bone marrow. And the two main tests that you can use to test MRD are flow cytometry and next-gen sequencing. The flow cytometry can detect 1 in 10,000 CLL cells, whereas the next-gen sequencing can detect 1 in 1 million cells. So a little bit different. You got to pay attention to where you're testing it, what technique you're using to test. But currently, the only FDA-approved technique is the clonoSEQ testing through Adaptive, and that's the next-generation sequencing. And that was approved based off of testing that we did with venetoclax. So in general, I always treat my patients for 1 year. I say always, but obviously there's some scenarios where I'll continue. But I try to really treat them for 1 year in the frontline setting because when I go down the pathway of venetoclax, I go on this unwritten contract with the patient that it is time-limited therapy. Otherwise, we could have picked the BTK inhibitor. So in general, what I do is I do test for the MRD testing. You have to make sure you send the sample before you start the treatment because you need to get the ID of the CLL, and the ID is actually the immunoglobulin heavy chain variable sequence, which we talked about being before mutated versus unmutated. So you can actually use this clonoSEQ test to test for mutated status. And then after they're done with their treatment, you can retest to see if you can still detect the CLL left in the peripheral blood or the bone marrow. And usually we use this for prognostic assumption. So if they still have detectable disease after finishing venetoclax, they tend to have a shorter PFS than patients who have undetectable disease. And we now have some data from the Murano study, which compared VR to BR in the second-line setting, that shows that some patients who had undetectable minimal residual disease after treatment are years and years and years and years out from therapy. So there's patients who have undetectable disease after finishing venetoclax tend to have a really long duration, and we're hoping that they have really a long duration of remission until they, live for the rest of their lives. But time will tell.
Do you think that we could potentially cure CLL, Adam? It's one thing you could have a functional cure where you're fine and you die of something else, and you can have an actual cure where you literally get rid of the disease. These MRDs are not picking up. Do you think that we're actually curing some of these people?
I think I'm always hopeful, but I think that it's probably far off, and that most of these patients probably do have some detectable level of CLL. We're just not going deep enough. And whether or not, if you get to a CLL that's deep enough, is the immune system taking care of it from there, right? Is the immune system doing its job and keeping it at a low level moving forward? It's kind of hard to know, but hopeful, but I think time will tell.
When you think about these assays, come on back on Saturday for lunch. We're going to talk about prostate cancer because their PSA has for years already been doing what we're talking about here in terms of MRD and other assays there. And in prostate cancer, they're using that to, earlier and earlier therapy. This patient, what was her MRD assay, Jackie? And what do you usually do at the end of 1 year if the patient's still MRD positive?
If they're still MRD positive at the end of the year, we usually put them on leave them on the BTK inhibitor.
Really?
For maintenance therapy.
How about your patient here? What was the MRD?
Oh, this particular lady, she made the choice that she would prefer not to continue treatment. She was less than 0.01%. And so even though it was still showing a small clone of CD5 positive cells, treatment should be something that you collaborate with your patient on. So we will follow her very closely. Every 3 months, we'll see her back, and we'll be following we did do clonal sequencing on her as well, and she did have a few cells remaining. So, that was her choice, and we'll just monitor her very closely for progression.
So we're going to go through a couple more cases just to provide more of a clinical flavor of how these patients are treated. But another issue, Adam, is the potential. Actually, we're oncologists. We find two good things, we put them together. And we are seeing studies now with the logical thought, okay, if BTK is great and venetoclax is great, why not combine them? There are a bunch of studies out there right now, Adam, looking at combinations. Curious what your thoughts are about that, both in terms of tolerability and efficacy. Do you think that when we come back here next year, we're going to be using combinations or sometime in the next few years?
Yeah, so the question about combining therapies in oncology is always whether or not combining therapies is better than sequential therapy. And I think this is going to be a really long time before we have an answer to that question. But there are some studies. The GLOW study recently read out, and that's a combination of ibrutinib plus venetoclax versus chlorambucil plus obinutuzumab. The biggest gripe with that study was the comparator arm, where people thought that comparator was a weak comparator. And in general, the combination did really well. There's another study out there that is pretty far along. That's the Captivate study that Dr. Allen has been integral with, where ibrutinib plus venetoclax is combined, and there was two other arms where MRD-guided therapy allowed for continuation of therapy. And once again, the combination seemed to be very effective. In general, we're not seeing any weird toxicities from the combination. Mostly the toxicities that we're seeing are additive, so what we'd expect from a BTK inhibitor and what we expect from venetoclax seems to be just co-occurring when we give them together, so we haven't seen any sort of new toxicity from the combination. Now, whether or not, as I said, the combination will be better than giving it sequentially, I think is to be determined. And I think it's always good to have more options for our patients. I think that specifically for this particular combination, it's really good for that patient who wants all oral therapy. So right now, the only time-limited therapy we have is venetoclax plus obinutuzumab or rituximab. So the infusion is required, and I typically always give it with the infusion. And so the combination of a BTK inhibitor versus venetoclax might be good in somebody who wants to take all oral therapy who may not want to come to the infusion suite. But we don't have any data to say that the combination is better than sequential therapy just yet.
I keep getting these flashes back, and I remember we were doing a program, it was about 10 years ago, and I said to an investigator, okay, well, what do you think the best therapy is? And he was like, well, you have FCR, you have BR. And then I said, well, what would you like to get? And he said, ibrutinib, which wasn't even approved at that point. So I want to go back to you, John, and ask that unfair question also. Well, if you had CLL or if somebody in your family had CLL right now, would you want to get a combination like something that you've been studying? Or do you think it'd be more prudent to, again, do the sequential approach?
Yeah, I mean, I think right now we've moved beyond chemotherapy. So I think if there is a clinical trial option in frontline settings and you're looking at targeted agent combinations, no matter which arm you get, you're going to be getting an unbelievable therapy. So I think I encourage most of my patients, if there is a frontline study, to enroll, because most of these studies nowadays are very modern and using the best drugs and with modern endpoints, et cetera. So I mean, I think it depends. This is the thing with CLL, is that because the expectation is for a normal life expectancy and the expectation is to care for people even on treatment over 2 decades maybe or longer, that what was important in their 60s is now maybe not so important in their late 70s. And this is something that where shared decision making becomes so important, and reevaluating the patient preferences, the stage of life, where they have, do they summer in Florida? I'm in New York, so everybody goes to Florida, and they don't want to be coming to us for venetoclax or obinutuzumab constantly. So all these things change. I'm sorry, winter in Florida, not summer in Florida. But
summer.
Regardless, these things change over time. And so I think, there is no answer right now. We have some of these studies that have been spoken that are looking at head-to-head, stop versus continuous treatments and combination therapies, triplets and doublets. We will have the answer maybe in 5 years, but I honestly believe that no matter what approach you take, you're probably going to be fine. We're learning you can retreat, you get responses again. Yes, remissions may be shorter after you stop treatment, but they're still going to be years into the future, and there's benefit to being off of drugs. So I don't know if we'll have definitive answers, but we might identify certain patients that probably might be best, particularly high-risk patients, for certain approaches.
Adam referred to sort of an MRD adapted approach, and again, prostate cancer, you see that using PSA. What about that kind of more of a dynamic strategy, John, where it's not, you're going to stop at a year, but it kind of depends on what your MRD is?
Yeah, I mean, I think that's really the holy grail. Without trying to be so cliche about it, this is where you can truly personalize your treatment. You can optimize the therapy for that patient, and if you can get a response-adapted approach, it becomes very clear. The issue with that is that it has to be easy to implement without a lot of complicated, calculations or serial monitoring, because that then starts to decrease the utility, particularly in community settings. Particularly in patients' practices that they have 5 CLL patients, but they have majority colon, breast, prostate cancer patients, that they're not up to date on all this nuance. And so it has to be simple. We're not quite there yet. These studies are now being designed to make it simple and have very strict decision points to have very clear decisions made upon that result.
All right, let's talk about a couple more cases. Again, get more of a clinical feel management of these patients. And Corinne, this is a patient who really has, a syndrome that has a lot of attention. Again, kind of a new thing to oncology, having atrial fibrillation as a complication of treatment. But here it is. What happened with this patient?
Yeah, so she had no history of atrial fibrillation, no cardiac comorbidities, and her EKG before she started treatment was just normal sinus rhythm. But after about 7 months being on the ibrutinib, she started to report these palpitations she would experience just watching TV at home. A lot of times if she was lying down at night, we would do an EKG in the office, and that, those were non-revealing. So her family doctor eventually set her up with the cardiac monitor that did show that she was having episodes of atrial fibrillation. So she immediately notified us, and we referred to cardio-oncology. Someone in the community might just go to regular cardiology, which is fine as well. And so they assessed her for appropriateness for anticoagulation and rate control. So she was ultimately started on a beta blocker and apixaban, and she was able to continue the ibrutinib throughout this process because she was rate controlled and because her symptoms were overall manageable.
Jackie, can you talk a little about your experience with atrial fibrillation, how it presents? In this case, it seemed like it was kind of not a dramatic presentation. What are some of the spectrum of how people get present with this syndrome? What have you seen?
Well, as she stated, most times patients may have been feeling palpitations, but they don't know quite how to define it. Sometimes they'll tell you that when you're doing your review systems, and sometimes they don't. But if the patient tells me that, as Corinne said, I urge them to, see a cardiologist. The problem with AFib, if you don't record it while you're in AFib, you'll never find it. So we used to send them to our cardio-oncologist. We have had many patients who they put in an implantable cardiac monitor so that they were able to monitor the patients. Generally, if it is confirmed, we don't stop the drug. We just put them on. They are treated with beta blockers, usually metoprolol or something, to try to manage that. And then you have to be very careful about telling them to take aspirin and those type of things because they're already at risk for bleeding. But just very briefly, I had a lady. This lady was about 72, I would say. She came to clinic one day, and she had been on ibrutinib now probably about 6 months. She was sitting on the exam table. As I was listening to her, I could hear that she was in AFib. The heart rate was maybe like 129, 130. I told her, I said, do you feel your heart palpitating? She said, no, it feels the same way it always feels. So I'm thinking, how long has she really had AFib? So surely she was in full-blown AFib and ended up having to be cardioablated. Needless to say, she was no longer a candidate for AFib, for ibrutinib. So those are some of the things I've seen over the years.
What's the current status of this lady?
She's doing fine. We were able to obviously take her off of that drug, but now she is actually safely being treated with acalabrutinib, I think, and she has not had any reactivation of the atrial fibrillation, although she's still followed by a cardiologist loosely. But I tell all my patients who tell me that they've ever had heart palpitations to go buy an Apple Watch, because it will tell you if you're in AFib. So, but the lady's doing fine. She has not had it since the ablation. She has not had any recurrent episodes of AFib.
And Corinne, how about your patient?
She's doing well. She did recently transition to acalabrutinib just because she was having some persistent palpitations, and just knowing that atrial fibrillation is a lower frequency with that medication.
So I think we have one more case I want to hear about, this 68-year-old man who got obinutuzumab venetoclax. Is that your patient?
Yeah, so kind of similar to some issues that were previously discussed with this regimen. He had progressed on acalabrutinib and then started into this regimen. There was an issue that precluded him from rituximab after having a bad reaction to that with a local oncologist in the past. So that's why this regimen was chosen. But he got through the ramp-up phase without any issues with TLS. But about cycle 4, he started developing issues with neutropenia, grade 4 neutropenia. So he did treat through with growth factors, but it occurred multiple times that he would come back for treatment. We'd have to hold treatment, resume the following week. And he also had a lot of side effects with growth factors. So he wanted nothing to do with growth factors anymore. So we did have to be a little bit aggressive with dose reducing the venetoclax, and eventually he was able to kind of maintain an adequate neutrophil count with a venetoclax dose of 200 milligrams for him.
What's it been like to take care of him?
It's been a lot. I think he was so used to the, acalabrutinib was very easy for him. He'd come every 3 months or so. Didn't really think about his CLL between visits too much. So this was just different because he was coming a lot more often. And I think what's important for these patients too is to create the expectation that sometimes you might feel really well, but you come to get your treatment with this regimen and we might need a delay or hold, so you have to be a little bit flexible. But since he traveled from an hour and a half from a rural area, it was just very cumbersome for him to come and not get treated. But we got through it, and he's back to doing home projects, and we only see him every 3 months now.
I know I've heard that at Ohio State you have a program for people who live far away, have difficulty getting into your clinic, of so-called accelerated ramp-up, bringing a patient into a hospital who's going to get venetoclax, and instead of taking the 5 weeks, do it very quickly under intense observation in the hospital. I want to ask Adam about that as well, but also from your point of view, Corinne, how that plays out. Have you had any of your patients do that? Yeah,
we have had a few patients do this rapid dose escalation. They're chosen for this for various reasons, and I'm sure Dr. Kate will elaborate more on that. But they get admitted, and they first receive a pretty aggressive hydration overnight, and then take their first dose the next day with close lab monitoring in the inpatient setting. So they get hydration through the day, labs checked, 6 to 8 hours later, and then again at the 24-hour mark. And if there's no signs of clinical TLS, then they can escalate to the next dose until they get to the maximum dose. And that hospitalization is about a week unless there's delays because of TLS.
Adam, any thoughts about that? I think you have seen patients get to the edge of TLS there. You're almost pushing the envelope there, but from a practical point of view, it's great. Again, particularly for patients who live far away. Do you ever do that?
Yeah, you have to be very selective on which patients you allow to do this. So I typically reserve this for patients with good cardiac function and minimal kidney dysfunction as well, because the problem is that if you do run into clinical TLS, you're going to have to give them a bunch of fluids. And I've run into trouble where patients get fluid overloaded, they go into heart failure, things like that. So I really am very selective about who I let do this. It's typically people that live far away. The other situation that we do this, and that we do this all the time, are patients who have basically accelerated CLL who come to us who are just in really bad shape and just need to go on therapy right away. So those patients we do to this as well, where we admit them and we do the rapid dose escalation. But for standard treatment-naive disease, I'm very selective about who I let do this. They really have to be in good health.
You know, this is not something to be done in a community setting either, and I guess you all are one of the few places even looking at this. We want to close out with a little bit of a vision for the future. We're going to hear about this case that Jackie has, really amazing combination, pirtobrutinib, obinutuzumab, venetoclax. That sounds really interesting. But John, just to come back to you, this morning we talked about diffuse large B-cell lymphoma and the revolution that has occurred there, first with the introduction of CAR-T, and then now with bispecifics, and tremendous excitement about that strategy. But you also see that, and it's been looked at in CLL. Can you comment on what we know about that in CLL and whether you think that's in the future? And even right now, do you send patients for trials of bispecifics? Do you ever refer patients for CAR-T?
Yeah. So CAR-T bispecifics, they have some relevance in CLL, obviously because we have these wonderful small molecules and we keep developing other small molecules that work really well and are safe. You know, immunotherapeutics kind of keep getting pushed off into, further and further lines of therapy. With that said, CAR T cells are very effective in CLL, particularly several products have been tested. They can achieve high rates of MRD negativity. Some of the issues with it is that you're using a CLL T cell to make these products that are typically inherently kind of disrupted and dysregulated and not ideal necessarily. And so some of the outcomes long term haven't been as great as what we've seen with follicular lymphoma or mantle cell lymphoma and or even DLBCL, though it kind of looks a little bit like DLBCL. Bispecifics, again, are getting into the CLL treatment paradigm. Small numbers of patients have been treated, though there's encouraging data. Again, you're using an inherent T cell defected cell. Is that why we may not see as strong of responses as we've seen in other histologies? Remains to be seen. But these drugs are there. They are absolutely going to be needed, I think, because there are going to be 20% of patients that are still breaking through these new drugs that we need immunotherapeutic approaches for, and they are being developed, and I expect in the next several years we'll probably have them as an option in CLL.
Actually, I remember when CAR-T came in, and one of the first cases was a patient with CLL who had was dying, had an incredible response, and then everybody was like, oh yeah, we're going to be using CAR-T for CLL, but then, BTK, venetoclax came along. There was no need to think about it. Let's finish out with this last case. Again, younger patient, 59 years old, Jackie, with CLL, and goes on this fascinating combination. What happened?
Well, simply put, this was a young male who came in and had bulky disease, and so obviously we look at the prognostic factors, the NGS profile, next generation sequence, and this guy had a Notch1 mutation. We know this occurs in about 30% of patients who have Richter transformation. He had other characteristics that suggested Richter's, and after the PET scan and biopsy, he was Richter's, and so he was started on trial with pirtobrutinib, obinutuzumab, and venetoclax. And he is now in his second or third month of therapy. The patient's disease is remarkably improved. He's doing well, not going back to work just yet, not full time, but his quality of life has improved significantly. The lymphadenopathy has pretty much subsided, and like I said, the patient is tolerating the treatment well. It is not without some concerns because the main problem we're having with him is the neutropenia, I guess, if any. But he's tolerating the pirtobrutinib very well. And so this therapy, this triple therapy, as we call it now, looks to be very promising even outside of Richter's for patients with more aggressive forms of CLL.
So, Adam, I know you have a particular interest in Richter's. Can you kind of explain what Richter's transformation is, how we treat it, and whether or not some of the new therapies are encouraging?
Yeah, so Richter's transformation is when CLL transforms into an aggressive lymphoma. It can either be Hodgkin's disease or diffuse large B-cell lymphoma or high-grade B-cell lymphoma. So the classic one is going to be the high-grade B-cell lymphoma or diffuse large B-cell lymphoma. Patients who do transform to Hodgkin's disease, as long as they're being treated with a Hodgkin's regimen, they typically do very well. So talking about just those patients that transform to a diffuse large B-cell lymphoma or a high-grade B-cell lymphoma, these two patients do notoriously poorly. So about 10% of these patients have what we call de novo diffuse large B-cell lymphoma, so meaning that they just so happen to get diffuse large B-cell lymphoma in the setting of CLL, but they're unrelated. But 90% of those patients, they have related disease, meaning their CLL literally transformed into an aggressive lymphoma. And so overall, these patients do really poorly. Recently, we published that patients who develop Richter's transformation in the setting of our novel therapies have a median overall survival of 4 months, really a dismal disease, really needing new clinical trials. And so in general, there's a couple of new studies that have been reported that look pretty good. So there's a single agent pirtobrutinib that was presented at the last ASH meeting that showed patients had an overall survival of about 13 months, which is really great for Richter's transformation. There's combination venetoclax R-CHOP that's being studied that had really good outcomes reported. We have a study at Cornell that Dr. Allen's leading that combines polatuzumab with R-CHP. And then I have a study, too, that's coming out with zanubrutinib plus CAR T-cell therapy for Richter's transformation. So really an area of dire need of new therapies. And typically, we are giving new things like combination small molecule inhibitor with chemotherapy or combination therapy with, like this patient got with pirtobrutinib, venetoclax, and obinutuzumab.
BTK plus CAR T. That sounds really interesting. The idea of getting the immune effect of the BTK on top of CAR T?
Yeah, so as Dr. Allen has said, with CAR T-cell therapy, the reason why we think it might not work as well with CLL is because you have a T-cell that is not functioning very well. So there's a lot of good data out there that shows that BTK inhibitors actually boost the function of T-cells in patients with CLL.
So I mentioned our interest in what the trend in oncology, looking at biomarkers and determining therapy based on the biomarkers in the patient's tumor tissue. Tonight, for the first time in all these years doing ONS, we're going to do a meeting focused on a biomarker, which is HER2, and we're going to talk about it in several different cancers: breast cancer, lung cancer, colon cancer, upper GI cancer. 6 o'clock tonight. Thanks so much to the faculty. Thank you for attending. Have a great day.